Hello, my name is Adam Kirking. I'm a Director of Operations with Imperium Health. I'm excited to be here with you today to discuss two of my favorite topics, ACO quality measures and the ACO quality audit. ACOs participating in the Medicare Shared Savings Program must report quality data to CMS at the close of every performance year. This reporting is a requirement to be eligible for any shared savings. And the ACO's performance on the quality audit actually impacts the percentage of shared savings the ACO is eligible to receive. The quality audit is divided into four sections. Clinical quality documentation, we'll sometimes hear this called the GPRO, is the submission of quality information that was documented in the practice's medical record. We tend to spend the bulk of our time focusing on the clinical quality documentation measures because we have the greatest influence on those. The ACO is evaluated on claims-based measures, and those are measures that CMS calculates in the background based on attributed beneficiaries. Those are focused on admissions, readmissions, and advanced imaging utilization. Every ACO is required to participate in a CAP survey or an ACO CAP survey. This is included in the ACO's overall quality score. And promoting interoperability, formerly known as advancing care information, and I guess formerly known as meaningful use, is the fourth component of the ACO's quality audit. Promoting interoperability is reported by each individual ACO participant, whether that's an individual provider or a group. A few key dates to remember as we think about our quality audit. We're working on performance year 2018, which extends from January through December of 2018. Our clinical quality audit, or that GPRO audit that we do, will occur from mid-January through mid-March of 2019. When we turn our information into CMS, it must be in by mid-March. So that when we get closer to the audit, we'll release some more defined timelines for that. But just remember, mid-January through mid-March. Those clinical quality measures are divided into three sections. First are some 8 preventative measures, 5 at-risk measures, or measures for patients at-risk populations, and 2 measures that are considered to be care measures, and I would say these are measures for the patients when they're in their most vulnerable state. These 15 measures are going to be reported in that GPRO process, or that group practice reporting process, from mid-January through mid-March of 2019. And those quality measures are going to be reported through ACO Health Solutions, or using ACO Health Solutions. The first of those clinical quality measures is the breast cancer screening measure. The target population for this measure is women ages 50 to 74 during performance year 2018, meaning that if someone turned 75 during 2018, they would not be eligible for the reporting of this measure. That's not to say that's not great quality care for a woman that's age 75 to get a mammogram. It's just the CMS specifications, we're not required to report on that. To meet this measure, a woman would have had to have a mammogram or a 3D mammogram, oftentimes called tomosynthesis, done between October 1st of 2016 and the end of this year, so December 31st, 2018. The 2 exclusions for this measure are women that have had a bilateral mastectomy or 2 unilateral mastectomies. As a tip for you, I would always recommend setting up alerts in your EMR to identify when a patient is going to be due for a mammogram. Always make sure that you're asking about active mammogram status as part of a well visit. And you can take the patient's word for it as long as you have documentation of when, where, and the results of the mammogram. The next preventative measure is the colorectal cancer measure. This is for beneficiaries between ages 50 and 75 during 2018. There are a few different tests that can be used to satisfy this measure, and it's any combination of these tests that can be used to meet the measure. First, and one of the most common, is the fecal occult blood test, sometimes called the iFit test. That's a once-a-year test. The FlexSig, or the flexsigmonoscopy test, is a once every 3 years test. A colonoscopy is a once every 10 years test. CT colonography is a once every 5 years test. And a fecal immunochemical test, or the oftentimes called a Cologuard, is good for 3 years. The exclusions for this measure are patients that have had a past history of colorectal cancer or anyone that's had a colonoscopy. The next two quality measures are related to immunizations. The first is the flu immunization, or the influenza vaccination, and this is for all Medicare beneficiaries ages 6 months and older. It's rare that you get a Medicare beneficiary 6 to a year old, but it certainly is possible. And the expectation is that we're giving those patients a flu shot, or documenting, well, maybe why we did not give a flu shot during the flu season. So as a reminder, the flu season that we're going to be reporting on in January, February, March was actually the flu season from the end of 2017 and the start of 2018. And the flu season that we're in now is actually for the quality audit that we would do in January of 2020. The three exclusions for the influenza immunization measure are patients that have refused, patients that it was not medically appropriate to give an immunization to, or flu immunization to, or a system reason like maybe we ran out of flu shots or ran out of our influenza immunizations. All three of those are considered to be acceptable. However, we must have an exclusion documentation or some reason why we did not give that flu vaccination during the performance period. The next measure is the influenza immunization. This is for all beneficiaries ages 65 and older. We need to make sure that for those patients aged 65 and older, we've documented if they've ever had a pneumonia vaccination. If they've had it done after January 1st of 2015, we must document the type of vaccination they've had it done. The vaccination doesn't need to be given when the patient is older than 65. It's just the target population for this measure is any beneficiary 65 and older. And there are no exclusions for the pneumonia vaccination measure. The next two preventative measures are screening and follow-up measures. The first is the BMI screening and follow-up, and this is based on, or the target population for this measure is any beneficiary ages 18 and older. The goal of this measure is to make sure that we're recording a BMI on our patients at least once a year, and if the BMI falls outside of range, we develop a care plan or a follow-up plan for that patient. The follow-up plan does not need to be the most exhaustive plan in the world. It just needs to be something that encourages or sets a plan for the patient to be a little bit healthier. Patients who are pregnant or refuse to have their height or weight measured are considered an exclusion for this measure. And any elderly patient whom weight reduction or weight gain would complicate underlying health conditions such as illness, physical disability, mental illness, dementia, nutritional deficiencies, or mineral deficiencies, the follow-up plan is not needed for that, and those patients are going to be considered an exclusion or an exception. So let's just make sure that for those patients we have that documented for ourselves. You can use a combination of height and weight measurements recorded during the year. You just have to have at least one of them done during the year, and then use that to calculate the BMI during the performance year. The other preventative measure that involves a quick follow-up or quick screening is the tobacco screening and cessation measure. For this measure, we're required to do a screening of tobacco use or tobacco products use from January 1st of 2017 to December 31st of 2018. Documentation of that counseling is also just as important to make sure that it occurs during the year, and that counseling could be a simple discussion related to tobacco alternatives or health risks associated with tobacco use. And for the exclusions for this measure, the exceptions for this measure, are patients that it doesn't make sense to do a tobacco screening because of medical reasons, maybe limited life expectancy, or patients that maybe it doesn't make sense to do an intervention. Again, maybe limited life expectancy or some other medical reason why it wouldn't make sense to do a tobacco follow-up. Or documentation of underlying conditions that could be exacerbated by a tobacco screening or follow-up. The next preventative measure is a depression screening and follow-up. The target population for this measure is going to be any Medicare beneficiary ages 18 and older without a prior diagnosis of major depression. For this measure, it's important to make sure that you're using a standardized screening tool for your patients. That could be a PHQ-9, the Beck Depression Inventory, the BDI test, or it could be the PHQ-2 test. I would advise the group, if you're using the PHQ-2 test, if the patient tests positive for either of those first two questions, it's recommended that you do the full 9 or the full PHQ-9 test to ensure that we're accurately screening the patient for depression. For this measure, we not only have to do a screening, but if the patient tests positive for depression, we must use that score or as a kind of way of ruling out whether or not the patient has depression, and if they do, we have to come up with a follow-up plan that day. A couple of options or great examples for follow-up plans are maybe an additional screening, maybe a suicide risk assessment, maybe a referral to another practitioner, some sort of pharmacological intervention, or it could be some other follow-up plan like exercise or a change in diet. The next preventative measure is statin therapy for patients with cardiovascular disease. So for this measure, there are actually 3 different target populations. The first is beneficiaries ages 21 and older who were previously diagnosed or currently have a diagnosis of atherosclerotic cardiovascular disease. Patients ages 21 and older that have ever had an LDL greater than 190 or who were previously diagnosed or have a current diagnosis of familial or pure hypercholesterolemia, as well as patients ages 40 to 75 with a diagnosis of diabetes with a fasting direct LDL of 70 to 189. This can be one of the tough measures to make sure that we're staying on top of because there are so many different potential patients that can fall into this grouping. I would encourage you to make sure that you're using ACO Health Solutions to identify those patients that will likely fall into this category, as well as using your best clinical judgment. There are no exclusions to this measure except for patients that are pregnant or actively breastfeeding, or patients that have a previous diagnosis of rhabdomyolysis. When I'm identifying patients for cardiovascular disease, a couple key words to look for are acute coronary symptoms, stable or unstable anginas, or coronary arterial revascularizations, oftentimes called a CABG. The next section of measures is going to be those clinical quality measures, and these are those measures for those most vulnerable patients. The first is a medication reconciliation post-discharge. For this measure, it's going to be important to make sure that we're documenting that we have reconciled any discharge medications with any newly ordered or clinic medications. One of the easiest times for a medication error or for a patient to be readmitted is after they've just been discharged to their home. So for the focus of this measure, we're after a discharge from a hospital, skilled nursing facility, inpatient rehab facility, or a long-term acute care facility to a patient's home or to that community home like a nursing home. For this, we need to make sure that we're doing a medication reconciliation within 30 days of a discharge. This is the one quality measure that's not really addressed or closed through the annual wellness visit, although this measure can be closed through a transitional care management visit. The other care measure or measure related to those most at-risk beneficiaries is the screening for future fall risks. For this measure, we want to make sure that we've documented a fall screening. It does not need to be a written fall screening. It can be as simple as asking the patient, have you fallen in the last 6 months? Have you fallen in the last year? I would always encourage a patient to, or when medically appropriate, to maybe have them stand on the exam table. So an exclusion for this measure is any patients who were assessed to be non-ambulatory during the measurement period. And that should be on the last date of service that you did that fall risk screening and diagnosed the patient as being non-ambulatory. For this measure, one of the things that you can do to help to be successful is to do some codes that will make sure that you're capturing that information through ACO Health Solutions. You can use a 1100F code, which is patient screened for future fall risk, patients experienced 2 or more falls in the past year, or any fall without injury. 1101F, patient screened for fall risk, no falls in the last year, or 1 fall without injury in the last year. Or 3288, fall risk assessment document. Those are great ways to make sure that we're capturing the information on our patients over the course of the year and entering it into ACO Health Solutions. The diabetes measure can be a tough one because it's essentially a composite or a 2-for-1 measure. So it's important to not only do well with our controlling A1Cs for that diabetic population, but it's important that we make sure that those diabetics are getting their regular retinal or dilated eye exam. For the A1C measure, we need to make sure that the last A1C of the year is less than 9. One of the tips that I would always have for this is to try and make sure that you're doing a regular A1C on your diabetics at least every 6 months, or recommend the patient gets their A1C checked at least every 6 months. And potentially recommend that those diabetics be referred to a diabetic educator. For the diabetic eye exam, the patient needs to have a retinal or dilated eye exam performed in 2017, the 2017 one was negative, or 2018. So again, a reminder, these measures, or all of the quality measures, are based on a performance period. So for the diabetic eye exam, if you had a negative diabetic eye exam in 2017, that would satisfy the measure. If it was positive in 2017, you'd have to redo it in 2018. The most important part of the diabetic eye exam is getting that documentation done as well. So first the patient has to go, but then we need to make sure that we know about it. You can take the patient's word for it if you trust that the patient will tell you the day, the provider that they saw, location, and the results of it. Now it can be close, but we just need to make sure that we know that the patient got it and what the results were of the test. One of the most difficult measures is clinical quality, or trying to improve the major The next measure is depression remission. This can be one of the most challenging patient measures, because trying to get that patient with a previous diagnosis of major depression or dyspnea to no longer be depressed or no longer have a PHQ-9 score greater than 5 can be very challenging. For this, I would always recommend trying to do additional counseling, considering medications for the patient, just to make sure that we're getting those depressed patients the care that they need. As I'm thinking about this measure, the key exclusions are patients that are permanent residents of a nursing home, patients with a bipolar disorder or some personality disorder. So a couple common examples for those bipolar or personality disorders are maybe a manic, bipolar, paranoid, schizophrenic. If a patient has one of those conditions, they would be considered excluded from the measure. We wouldn't need to worry about them. This can be one of the most difficult measures to be successful at for a few reasons. One, it's hard to get that patient to have a lower PHQ-9 score. And the other is, it's hard to ensure that we've guaranteed we've done that historical PHQ-9 score on the patient. A best practice for this measure is to make sure that you're always including a PHQ-9 whenever possible with your annual wellness visits, or whenever you do a depression screen, even if it's a BDI, that if the patient does test positive for major depression, that we're doing this PHQ-9 score as well, just to make sure that we have as many tests as possible to identify that patient as being, or as having a diagnosis of major depression. The next clinical quality measure, focusing on those at-risk populations, is the hypertension measure. This is going to be focusing on patients ages 18 and older with a diagnosis of hypertension at any time during 2018 or prior to 2018. For this measure, we want to make sure that we want to make sure that patients who have had a diagnosis of hypertension before 2018 or in the first 6 months of 2018 have had a A1 or get their The next clinical quality measure is hypertension management. This is going to be focused on patients ages 18 and older with a diagnosis of hypertension at any point prior to 2018 or a diagnosis of hypertension in the first 6 months of 2018. For this measure, we want to make sure that we get on the last blood pressure reading of the year a systolic and a diastolic less than 140/90. You can use any combination of readings on the last visit of the year to try and get that 140/90 combination. and you can mix and match different readings to get the optimal score for yourself. A couple exclusions for this measure are patients that were pregnant during 2018, have a diagnosis of ESRD, were on dialysis, or have ever received a renal transplant. Only blood pressures measured with or taken in the clinic count to satisfy this measure. So a blood pressure measurement taken and self-reported by a patient, or a blood pressure measurement taken by a home health agency, will actually not satisfy this measure. It needs to be recorded in the clinic. The next quality measure is use of aspirin or another antiplatelet for patients with vascular disease. For this measure, we're after patients that have had a previous diagnosis of ischemic vascular disease, or were 18 and older and had a AMI or a CABG during the year. For this measure, we're most concerned about trying to make sure that our patients have a documented use of aspirin or some other antiplatelet. To make sure that we're meeting this measure, it's always good to ensure that when you're speaking with your patients that you're asking them, what medications are you taking, including aspirin? Have you ever taken an antiplatelet? Have you ever taken an anticoagulant? We need to make sure that we have those things documented in our medical records. Ensuring that we have that information captured is one of the best ways to meet this measure. A few keywords to pay attention for in the clinical quality measure for vascular disease are aspirin use, Yosprala, or words like ischemia, occlusion, infarction, embolism, angina. Paying attention to those words can make such a difference in terms of identifying the right patients or the patients that have vascular disease and ensuring that we're able to meet it. Again, if we do not have documentation for any of those conditions during the year, this patient could potentially be an exclusion for the measure, or the patient could potentially be an exclusion for the measure. Those are the 15 quality measures that will be assessed on by CMS during performance year 2018. For those previous 15 measures, Medicare will identify 616 patients per measure, although they will identify 750 patients for the cardiovascular disease measure. And patients are assigned because of conditions or some sort of demographic combination. Medicare selects those beneficiaries because they meet a defined measure specification. As we went through those 15 measures, I'm sure you heard certain age ranges or certain disease conditions that would qualify the patient for the measure. Each measure has a unique defined target population, although many of the target populations do overlap. And whenever possible, Medicare attempts to select beneficiaries that would qualify for multiple measures. ACO Health Solutions is really going to be one of your best ways to find that list of patients, identify gaps in care, as well as other quality and operational things that can help to ensure we're meeting the needs for our patients. Patients can be selected for the audit by CMS even if they have not been seen for an annual wellness visit. It's important to try and utilize an annual wellness visit whenever you can to capture as much of the information as possible, as well as promoting that personalized prevention plan for our patient. Medicare identifies the specific patients and the specific measures for each patient for the quality audit. For example, on this table we can see a variety of different patients associated with different practices that are all eligible for different measures or going to be audited for different measures. Those blue numbers in the middle indicate when we report our information to CMS, the order in which we need to report them in. As you can see here, the patients are spread across a number of different practices. So when we report our information, ACO Health Solutions helps us combine all of those different patients from different practices into the organized report that Medicare would like from us. When you're doing your quality audit, you can take an approach where you maybe go one patient at a time. For instance, we could work on Rose Flynn's diabetes, hypertension, ischemic vascular disease, and depression. Or you could go one measure at a time. Like, for instance, for this example, maybe you know where your depression screens are all documented. So you'll be able to use ACO Health Solutions, identify the patients that are going to have a depression screen, and we'll go through the quality audit, selecting one patient at a time, but only focused on the quality measures. We will spend more time prepping and training for the G-Pro when we get a little bit closer. This is just a snapshot of what a patient list might look like. When we get closer to the audit, we will spend more time reviewing how to best document things within ACO Health Solutions to be successful with your quality reporting. A nice point of clarification I like to make on when we get closer to the audit, we will spend a little bit more time reviewing how to best document information in ACO Health Solutions. We will use ACO Health Solutions as a way to consolidate and report all of our information to Medicare. So you as a practice will likely be We will use ACO Health Solutions as our way of consolidating all of those different lists of patients and to be able to report it into CMS. You as a practice will be entering and completing the patient summaries within ACO Health Solutions, which will then be compiled by Imperium and reported through ACO Health Solutions to CMS. ACO Health Solutions is a certified clinical quality data registry, which means that it's one of the web interfaces that's allowed for the ACO quality reporting. When you go into ACO Health Solutions for the quality audit, again, we will spend more time training on the quality audit when it gets closer. You'll just be validating the information that's in ACO Health Solutions or entering it if it was not previously there. For any of the measures that have an exclusion, it'll be in a nice box on the right side of the screen so that you can identify, are there potential exclusions or other things that we should be looking for in the patient's chart. For this example, we can see potential exclusions related to the fall risk assessment measure. Within ACO Health Solutions, we always do need to make sure that we're validating the right patient and the patient is still eligible for the audit. For instance, if the patient may pass away during the performance year or enter hospice care during the year, but Medicare may not know about it yet. If that happens or the patient moves out of the country, we just need to make sure that we document that in the first part of the audit, and we will not need to worry about that patient for the rest of the year or for the rest of the audit. We can use claims data as a way to help us or almost kind of provide those breadcrumbs for ourselves. This is going to be a way to, when it gets time for the audit, always make sure that we're going to the right spot or track any progress on our measures over the course of the year. This is one of the best ways to make sure that we're tracking those gaps in care in our patients during the year. A few examples for that enrichment information may be use of CPT2 codes, those F codes and G codes, visit codes, procedural codes, or any information we're able to extract from your EMR. It's also possible to go in and do a manual entry or manual update of any quality information during the year. A few audit insights for you as we start thinking about it. Medicare will pick 616 beneficiaries for 14 of the 15 measures and 750 measures for the cardiovascular measure. So we will do our best to try and make sure that we're focusing on the correct patients over the course of the year, and I'm sure you will do the same. But it is a little bit random on which patients Medicare will select. A tip that I have for you is always make sure that you're training your MAs and your ACO leads on which patients are likely to be selected, as we're more likely to be successful on the audit that way. Quality must be reported through ACO Health Solutions. We're not able to do a separate extraction from an eClinical or just a pure report from eClinical. It does still need to be validated through ACO Health Solutions. We'll do plenty of training towards the end of this year to make sure that you're comfortable with how to report that information to CMS. I always recommend capturing information in a way that's easy to pull or easy to identify. Whether that's if you're doing a fall risk assessment, to try and put it in a spot that's easy to identify as opposed to burying it in the middle of a note. Or if we're entering our blood pressures, let's make sure that we're putting those in the correct fields so that it's easy to pull and export, or at the very least easy to find for your auditors. I would recommend training your team members so that they start to have a better idea for the target population for each quality measure, as well as the date ranges for satisfying those measures. When we turn our information into Medicare, we're required to submit a minimum number of beneficiaries. We have to submit a minimum of 248 qualifying consecutively numbered beneficiaries. And we will do our best to try and audit as many as we can, because we know the more we audit, the better our score will likely be. So the ACO will work with ACO Health Solutions to optimize that potential score to ensure that we're submitting the best 248 on behalf of the ACO. And beneficiaries are spread across all TINs, and it is somewhat random. It's not going to be just 1 or 2 practices. It will be spread across the entire ACO. Once we've completed all of our individual audits, so kind of get our percentages for each score, Medicare will then determine a performance rank or a performance score for each measure. This is something that will happen in the background and not necessarily something you need to be concerned about. For now, I would say just do the best you can with each measure. But do know that performance on each measure will potentially contribute to your MIPS score. The MIPS audit, or the MIPS score, is driven by the ACO's performance on quality and promoting interoperability, that replacement of meaningful use. All ACO participants are given an automatic full credit for the improvement activities. And participants in a Medicare Shared Savings ACO get a pass, or the cost component is excluded for MIPS reporting. A few key takeaways related to the quality audit. Practices should enter their information into ACO Health Solutions. Imperium will submit that information to CMS using ACO Health Solutions. And make sure that prior to the G-Pro, practices have identified who those auditors will be. We'll spend more time on that later this year, probably into November and December. Using quality codes is also one of the best ways to make sure that you're able to track your information. And not every patient will be audited, but those that are selected, we need to make sure that we're fulfilling the audit requirements. Thank you very much for your time today. I hope everyone has a great day.